It's my understanding that we have the smallest hospital in the state that still offers obstetrics. And there are a lot of us in this community that feel that that's an absolutely vital service. So T and Peggy, what are your thoughts on what a community can do to support that, besides having a lot more babies?
Yeah. You're absolutely right. Plumas' Mayor's Memorial in Fall River Mills just had to terminate its OB services.
And they fought hard to try and keep them. They tried everything to keep them, and that's just right up in Fall River Mills, and they just closed.
You know, I know that Dr. Keppel is very dedicated, as is his staff, to maintaining the service because it's vital to the community. He will tell you, and he's been very transparent, it is expensive as a service to do, especially when you don't have as many births. So I think as a community, what you want to do is support the full breadth of services that are offered at the hospital, so that the hospital can continue to provide those OB services. One way to support the full breadth is to make sure that there's a way to pay for the services that get offered. So use your voice in advocating for what you think is the best way to support a small rural hospital in this community. It trickles down. When you have to make the kinds of changes that the newest proposal is offering, then your hospital staff have to go back and reconfigure and look at the drawing board. And I'm going to tell you, OB's got to be at the top because of the expense of a service like that. So I think the best way to support is at a grassroots level by advocating for the full breadth of services that your hospital can offer, because then they can continue to provide OB.
Well, and I think, Dr. Keppel, is recruiting still a big piece of that?
Right now, recruiting OB nurses is the biggest piece.
What I was talking to earlier, if you know an OB nurse, if you have a friend or somebody with a daughter somewhere or something that you could twist their arm to come back home or move to this beautiful place, that would make a big difference. I mean, I don't mean to belittle. I know Dr. Keppel's doing a bunch of stuff to get the word out, and he's called me, and I have gotten the word out and trying. But the workforce shortages are critical. I mean, he's not the only one that's hunting for that OB nurse.
Right, that's the problem. That's the problem. You had a question.
I actually had a couple. I heard recently that a lot of people who are on Medicare, when they have certain kinds of needs, like long-term recovery, actually wind up needing Medi-Cal for that. That's correct?
That's correct.
Well, lower income people are the ones who are going to be in line for Medi-Cal, isn't it? Does that mean that it's people who don't think they're going to need it and will suddenly need it at the last moment because they're on Medicare? Those are the people who are going to get shut out because they're not, they're going to need it yesterday, and they'll apply, and these new standards are essentially going to make it harder for them to get in, particularly with kids. Does that sound right?
I think the eligibility that you're talking about will not generally be impacted as much.
Right.
That dual eligibility for those long-term care services,
right.
That's something California's covered.
So what you're talking about are people who are elderly but also disabled and will need that long-term care. So they're called something called dual eligibles. They're both eligible for Medicare and eligible for Medi-Cal. However, when you say, oh, so the line won't be shut on them, the financing of this is really, really complex. So if the whole system is changed, the overall financing for Medi-Cal goes away. And so we don't know how California is going to deal with, I don't think California knows how they're going to deal with that yet.
But we have a very fiscally conservative governor right now, I will tell you that.
And California has a long history of not funding Medi-Cal.
Right.
I mean, it would be, if all of a sudden the feds, you know, the ACA provides this pipeline of federal money to the state, and if all of a sudden it goes away, I don't think, it would be shocking if California said, boy, we need to step up and take care of that.
So okay, I'll hold my thought and then go ahead and ask your second question.
The results from that, at least, are ambiguous. It's not necessarily the case that they would be the most likely to be denied. The other question that crossed my mind is, I'm reading all this per capita caps. I mean, the whole criticism of the ACA is that it's government's foot on the healthcare system, and the biggest boogeyman in that is always rationed care. You know, that bureaucratically rationed care is the horrible thing that we're trying to avoid. How is per capita caps not rationed care? Aren't they enacting the boogeyman they've been threatening us with?
What they're doing is they're limiting how much they will fund, and then it's up to states to figure out how to divide that up with all the people you have to take care of. So you can call it what you want. You can call it ration care. You know, unfortunately, you know, to me, and this is just my personal, everything boils down to financing.
Yes.
If you don't have the dollars to do something, it's not an option. Political will can be there, just like the single payer, you know, 12 years in a row are making the legislative session. It's, if the money's not there to do it, it simply can't happen.
That's exactly right.
Yeah.
Yeah, I have a question about our hospital here. So, let's say if this new health care bill were to pass, would it really determine the viability of having a local hospital?
Might be best for you. You two.
You want to give it a try?
Do you want to bring up that slide in district hospitals reimbursements?
The Medi-Cal expansion and the 2,111 people that are able to receive services is just a wonderful thing. As a physician, I was seeing patients who had not seen physician for decades, and who were coming in and getting their skin checked out for an abnormal mole, or they just wanted some preventive care, or they were getting a colonoscopy when they needed to. So that was wonderful. In terms of what we get paid and the actual cost of care, it gets kind of tricky in terms of, is that really translating into more dollars for the hospital? I think if you include the supplemental payment programs, what they call the intergovernmental transfers, the hospital quality assurance fee, and now there's something called the rate range IGT that is big, that those dollars are vital, and they're actually pretty big for us right now. And that is coming from, you know, Medicaid dollars or Medicaid losses, which is ironic. You know, we call it Medicaid losses. They're going to backfill the losses, but in one sense, it's also helping to cover a lot of our other costs by just merely increasing our volume, because rural hospitals are like flying a 737 with 30 people. You know, we still have all the same regulations. We still have to comply, and OB is incredibly rigid. We have to have a surgeon on call. There has to be something called 30 minutes decision to incision. That means you have to have an anesthetist, an OB nurse, an OB doctor, a surgeon, an OR team, and an OB nurse, and an ultrasound tech, all available to be able to do something within 30 minutes. So those people aren't just going to hang out for free. So it's very costly for delivering 80 babies per year. So I believe that one of my MOs has been to expand services and increase volumes and increase community trust by providing great care, great providers, so that the community trusts us and come for not just sick services, but well services, and for fun things like delivering babies. I mean, it adds life to the hospital, and people that are there when they're sick, they actually like hearing the baby cry down the hall that just got born. It can be a wonderful thing. And we are going to be adding transitional care program July 1. where those patients that are being taken care of at Renown or Enloe or even UC Davis, after a severe acute illness and they need another 10 to 14 days of rehab, we're actually going to have a bona fide, robust program to actually have those patients here so the families don't have to travel to those big tertiary care centers. And the data on that, especially with this program, is that we will deliver better care and more attentive care for those patients that many times get lost in the big hospitals. When you step down out of that really acute care and you move into post-acute transitional, it's a lot about attentiveness. And I think we can do that well.
I would just like to add, there's, while what the HCA and ACA get a lot of press and everything, if you've been in the healthcare business any period of time at all, and I've been in it for decades, this one's more visible than most, but hospitals have a long history of getting pummeled. It's kind of what you do, and if you're a hospital CEO, you get pummeled on a regular basis. And my point is that hospitals have proven that they can take these punches and come back. And hospitals have a lot of resiliency, and I get a lot of optimism from that. And the other thing is, when I showed on the slide how you saw our two associations, we're also affiliated with two others. And between those four organizations, we cover the state, and we live in a state where our California Hospital Association and the three regional associations collaborate in a highly collaborative way that's unusual. Not all states have this. Some states have competing associations, and so we work together really well. And so whatever comes down the road, hospitals have a long history of getting knocked down and getting back up, and there's an association structure that's in place to help them do that is healthy, ready. You know, all this stuff that's coming down from DC and Sacramento, we're in the room. We're talking to the people. We know what's going on, and a lot of times we're able to shape things. A lot of times we're able to mitigate things, and we sure as heck don't get surprised very often. So I get optimistic.
So I'll be the pessimist. And I say pessimist, but you know, it's just important to know the truth. And the truth is that nearly 800 rural hospitals have closed.
Did she just call me a liar?
Wow, never. But it's the rural hospitals that live close to the margin is the way I like to call it. There's just not a lot of flush there. And so when you start to do things that impact your ability to just stay close to the margin, it doesn't take much to send you into the red. And, you know, I'm still surprised that the hospital in Colusa closed last year. This, you know, is a hospital that had been operating as the sole community hospital in the county. And now the county doesn't have a hospital. And so it's a delicate balance. And what worries me is if we start to play around the edges of those subsidy programs, of the way we pay for the people that need the care the most, it worries me about how our hospitals are going to be able to weather that.
The rural hospitals. I mean, the Sutters and the Kaisers are going to be there, but you're not going to see I shouldn't speak for them, but I don't think you're going to see a Kaiser clinic in Plumas County anytime soon. I don't think that's going to happen. And I mean, they'll survive and thrive, but the smaller community hospitals, to Peggy's point, are especially vulnerable.
I think we're going a little bit over our ending time. I want to invite one more question, and then I know that folks will be available for conversation and to answer more questions that way, but I just want to respect the end time of 7:30 that we have. Does anyone have a closing question?
And are there secret questions on the cards? I was hoping.
I checked the cards and there were no questions back there. So we would love one last
comment.
Yep.
I just wanted to thank Nance. Nance, would you stand up?
Yep.
Emailed me and said, what's going on with healthcare? We didn't know what's going on. And it have citizens who care and reach out to local government, and I wanted
That's
to thank
fantastic.
you. Yeah.
But now she's sad that she asked.
And I wanted to thank PDH, all the staff, Dr. Keppel, that helped get this together, and I know they wanted to be here, but representatives from Seneca and Eastern Plumas as well, so all of our local healthcare providers, the thanks goes to them as well.